Hey everyone, welcome to our penultimate session in SUPTA teaching series for this year. I've started the thing. Do you mind sending a message in the chat just to say that you can hear me before I get going? Anybody? Yes, thank you, Maria. Cool.
If it helps, I can hear you.
To join us, guys, my name's Connor. I'm actually the director and founder of SUPTA. I'll be facilitating Rashita's session today. Today we're going to be focusing on surgery. We're excited to have you all with us. Joined by Rashita Prabhu, who will take us to the topic. She's a student, but more importantly, she's one of the chair people of the SUPTA project's teaching session. So I'm looking forward to it. To make this session as engaging as possible, we'll be releasing polls throughout it. They're completely anonymous, so please start. It helps a bit, and it helps your learning. It helps that you're all paying attention. If you've got any questions throughout the session, just put them in the chat and I'll read them out to Rashita and she'll do a bit for you. At the end of the session, we'll share you a feedback form. To complete this, you'll receive a certificate of attendance and exclusive discount codes for some of our sponsors, including Teacher and Pass the MRCS. Important that I know that the session's being recorded and will be posted on our learning portal following the session. And all the slides will be shared on our medal page a couple of hours. Please keep an eye out for that. We're excited to share that we have an exclusive question and our other resources will be available on our learning supta.uk. So be sure to check them out after the session. Free membership with us and get access. And you'll also automatically receive a 10% discount Geeky Medics Anatomy flashcards, surgery flashcards, and knowledge bundle. We have an exciting opportunity for all of our attendees today. 2 lucky people will win free access to the Geeky Medics surgical flashcards and the Geeky stations. To enter, you complete the Google form, which we'll put in the chat of the session, and enter the unique code that we'll provide you with once you complete that. The sessions you attend have higher chances of winning, so be sure to stay at the end of the session as well as tomorrow's session as well. The teaching gets going. We'd like to thank our partners for this year, Geeky Medics, the MDU, More Than Skin Deep, Medal, Me Surgery, and Pass the MRCS. Finally, we have a quick announcement. This year's series is soon coming to a close. So after this week, so after tomorrow, we'll be moving to a different platform. We'll be moving away from onto a platform called Career, similarly, but in the future, that will apply to our national conference series. For example, those applying to F1, for those preparing for F1 training, that includes most of your final year. So please bear in mind that we will be switching to Career Book for every session for tomorrow. Anyway, without any further ado, I'll hand it over to Rashita, who will lead us through our session.
Thank you, Connor, and hello everyone. And I'm very excited to for this session. These are our learning objectives. I'm not going to read them out all to you. Just know that we're essentially going to be taking a whistle stop different congenital pediatric conditions that will affect different systems of the body. As always, if you have any questions, please do put them in the chat. As Connor mentioned, the session is going to be interactive, so please do engage with all the poll questions and also the questions that are called pediatric SHO. You've just started your shift now early and has just gone patient for today, Noah. So is a 3-hour-old baby who's delivered via a spontaneous delivery. While his mother was pregnant, was told that she had polyhydramnios. For anyone who may not be familiar with this, it just refers to excessive amniotic fluid within the amniotic sac. At birth, Noah's Ark scope was 9 at 1 minute. The myth mentions that he chokes when he's being breastfed. When you examine him, you notice the speck from the nose. So you take an X-ray to see what's going on. Can anyone in the chat tell me it off?
So guys, put in the chat for Rashita, and I'll read them out. There's nothing in the chat at the moment.
Okay.
Oh, we've got adenoid.
What I will say is, don't be shy to put your answers in the chat. We're all here to learn, so it's okay if you get the answers wrong. But if anyone, okay. Do we have any other answers in the chat? Noah's presentation is going to suggest esophageal is going to refer to appropriately. So atresia is when the esophagus hasn't formed properly, and more specific, it's going to end in a blind pouch. So if you look at the image, you can sort of visualize how this would look. To help you orientate, you're seeing this over here is your trachea, esophagus, and you can imagine the stomach to be somewhere down here. As you can tell, the esophagus is not a continuous, and you can see that it's ending in a blind pouch over here. Esophageal atresia is very commonly associated with another condition called tracheoesophageal fistula. Once again, if you break down this term, fistula is going to refer to an abnormal connection between two structures. So a tracheoesophageal fistula is going to be an abnormal connection between the trachea and the esophagus. Now this can come as, this is type A, also known as an isolated esophageal. It only have an esophageal atresia, and it's not associated with a tracheoesophageal fistula. Now, the second type is type B, a fistula with the trachea, but the bottom end of end is isolated. So this is going to be proximal tracheoesophageal fistula with a distal esophageal atresia. Would also be true. So that is going to be, the proximal end is going to be isolated, whereas the distal end is going to form a fistula with the trachea, with a distal tracheoesophageal fistula. So complete opposite. Now, the fourth type, or type D, is when both ends forming a fistula. So that's going to be called a distal tracheoesophageal fistula. So we've done 4 out of the 5 types. We're on to the final type, which is type other 4 types, in the sense that the esophagus is nice and continuous, as you can see, being formed between the esophagus and the trachea. So this is going to be called a tracheoesophageal fistula. It looks like an H. It's also referred to as an H-type fistula. That all of these names can be a mouthful, but I hope I've broken it down enough for all of you to understand the reasoning behind the names, which would sort of help remember it better. Now, tracheoesophageal fistulas, type E fistulas, are quite difficult to diagnose and is often diagnosed. This is mainly because there is no esophageal atresia. That is what is going to be red symptoms that esophageal atresia and tracheoesophageal fistula. I'll tell you more about these red flag symptoms. It's also going to be difficult to identify on an X-ray since it can show. And if you were to take an X-ray after not show any pathological signs we saw in the previous slide because there is no atresia. And we'll again go over this in a bit more detail in just a second. But if an X-ray is a type E fistula, what would be the most appropriate first-line mode of imaging if H-type fistula is suspected? Connor, could I ask you to release the buzz me, please? So you're going to have 4 options over here. We have A, bronchoscopy, B, a chest and abdomen X-ray, C, a contrast. I'll give you all a minute to think of your question. All of these responses are anonymous, so please do answer the question for me.
Coming in, give it another 30 seconds for some people to answer. At the moment, people are trying toward contrast CT.
Yeah, that's fine. Okay.
Okay, we're pretty split. We've got a third of people going chest and X-ray, and a third of people contrast CT, and the rest is bronchoscopy and barium swallow.
Okay, so I like to see a split, but the answer over here is going to swallow. So if you thought of stay, very well done. To diagnose a an H-type tracheoesophageal fistula, you're going to do a barium swallow. What you see is an X-ray of a child with a type E fistula. So once again, let's orientate ourselves with what we're seeing here. Lateral view of the chest and colon. In front of that, you see the esophagus, and in front of that is going to be your trachea. Over here, you can see the fistula that is there, and hopefully you can also appreciate that it looks like an H. Now, why wouldn't you go with the other options? While a contrast type E fistula, they aren't going to be the first line. It's just a lot. However, if the barium swallow if the barium swallow is incomplete, you might end up going with a bronchoscopy. But because my question was first line mode of imaging, previous slide is not going to be suitable because it's just not going to be picked up by an X-ray. Okay, so now how an tracheoesophageal fistula going to present? So prenatally, you might see nose and the esophageal atresia. The child swallows it. Now, in esophageal atresia, a blind pouch, the fetus isn't able to swallow it, and hence it's going to build up of amniotic fluid within the amniotic sac. You also see frothing or dribbling of saliva, which once again is due to the esophageal atresia. So because the child is in the mouth, which is going to lead to frothing or dribbling of saliva. You may also see coughing and choking during feeds. This, for a change, is because of the tracheoesophageal fistula. Since there is a connection between the esophagus and the trachea, the milk may be aspirated and can lead to the choke or the coughing. The next presentation is quite a big one and is one that sounds quite often. And this is going to be the inability to pass an NG into the stomach. And you can see the same thing on the X-ray over here. So the abnormality and this is the same X-ray that we used in the first slide, is that the G tube should normally be entering the stomach. But in this case, because the esophagus is ending in a blind pouch, there is a stomach, so it's going to coil within itself. So because it's the most insidious type and is often diagnosed later in life, during those years where it goes off pneumonia, pick up the fistula. So the food that the child is eating could be aspirated into the lungs, which is leading to pneumonia, and that's just essentially going to reoccur until the fistula. So how do we go about here, you ask? So the magnitude varies slightly depending on the type. But the main principle, the first thing you want to do is aspiration. And you do this by decompressing the upper pouch of the esophagus, or even an end tube to do this. You then want to go surgically at the esophagus as well as the fistula. Starting with the esophagus, you want to restore the esophageal continuity. And you can do this using different techniques, but to sort of determine what you're going to use, we do a gap study to assess length between both ends of the esophagus and then decide what you're going to do. As for the fistula, you're just going to have to ligate the fistula and the trachea and allow them to be two separate structures. Now, the principles of the surgery seems very simple, but when it comes to actually doing the complicated, because you have a lot of important structures around. If you damage any of the structures, it can have catastrophic effects. Okay, so let's now go back to Noah's case and quickly review what he had an esophageal atresia. I think that we need to know about it. I will give you a minute to read parts of this vignette. Tells us that, and I want you to put your answers in the chat.
Come on, guys. Any features from this history that you think indicate the patient may have an esophageal atresia? Luca Cox says postprandial choking, and Henang says polyhydramnios in the mother.
Yeah, so those would be correct. So you have quite a few clues within the vignette that's going to suggest that he has, and I've highlighted all of these reasons in the slide over here. You're also going to have the chest X-ray going to suggest that he possibly also has an esophageal atresia. I have discussed all of these features in the previous slide. I'm not going to go into much detail on it again. But one feature that it didn't specifically discuss was the barking cough. And this is very commonly associated with atresia and tracheoesophageal fistula. This is usually self-resolving, so it should settle older. Tracheomalacia is slightly outside of today's scope of the session. I'm not going to go into further detail about it. I recommend reading up about it if you are interested in it. Everyone, we've reviewed our first patient today, and hopefully you would have understood why we diagnosed esophageal atresia. With further testing, we figured that he has a type C fistula. And you're very pleased with yourself for being able to diagnose Noah, and you decide to go celebrate. But when you're on your way to treat yourself, your bleep goes off again. Review your next patient for today, and that's Charlie. So Charlie is a 10-month-old baby. He started showing signs of cyanosis and also had murmur. His mom also mentioned that there was some difficulty. And considering all of this, he was closely monitored. Fast forward to today, where Charlie's cyanosis and labored. His mom mentions that this started while he was playing with a sibling. You also, Charlie is in a knee chest position. So essentially imagine, what condition would you suspect for Charlie? I'm also going to give you another hint, put up on the screen. You wouldn't use this to diagnose someone with this condition, but it's just something that you might see in someone with this condition.
Lucas says TET, T-E-T. I'm assuming they mean tetralogy.
Mm-hmm. Okay. Right. So yes, you would
anyone else?
be correct. So this would be suggestive.
There's a bit of a no. Side, but I'm getting other bits of tetralogy.
That's all right. Okay. So yes, it is tetralogy of below, and you would be correct. So the chest actually that you see over here is showing. We'll talk about why we see this in a little bit. But before that, us revise the normal circulation of the heart and also talk about what tetralogy is. So starting with the normal circulation. So you're going to first get deoxygenated blood from the superior and inferior vena cava. From here, it's going to right ventricle, and then it's going to be squeezed up into the pulmonary artery, and it's going to pass through the pulmonary valve while doing so. Then you can imagine your two lungs to be oxygenated. From there, the blood is then going to be oxygenated, and that's going to be through the pulmonary veins, and it's going to enter the heart via the left atrium, then the left ventricle, and then it's going to go through the aorta and then supply normal circulation within the body. The main takeaway I want you to get from this is that from the left heart is oxygenate is going to be responsible for systemic circulation. So because this is going to go to the intake, it's really, really important that oxygenated blood is being briefly gone over that. Let's now talk about tetralogy of below. Tetralogy is going to tell us that there are going to be 4 coexisting pathologies. What we might see is pulmonary stenosis, which is just a fancy way of saying that there is narrowing of the pulse. So for the blood to overcome, it has to flow at a much higher pressure. And as a result of that, the right ventricle is going to have to squeeze harder. Now, because the heart is a muscle, if you're going to work it a lot, it's going to grow or hypertrophy, right? That is exactly what you see as the second feature of tetralogy of flow, and that is right ventricular hypertrophy. So because the right ventricle has to squeeze a lot harder for it to send blood pressure to overcome the pulmonary stenosis, you're going to notice right ventricular hypertrophy. Now, the third and fourth piece of TOF is an aorta, which I will tell you about in just a second, also a ventricular septal defect or VSD. The VSD. So usually the system that is going to separate the right and left ventricle is continuous, but the continuity is and hence the contents between the right ventricle and the left up. Now, in people with an isolated, this may not necessarily cause major problems because blood, any other fluid, is going to move from high pressure, which makes sense because that's just lies the pressure between the two chambers. And we know that normally the left ventricle and the right ventricle, deoxygenated blood wouldn't enter the left heart and hence wouldn't be circulated with someone in an isolated VSD. But tetralogy of Fallot tends to get things a bit more, mostly thinking about the right ventricular hypertrophy. So because of the hypertrophy, the pressure in the right ventricle is going to be high. So now there's going to be a right to left deoxygenated blood to go to the left ventricle. To make matters, you're also going to have the overriding aorta, which usually tends to sit on top of the VSD, and that's going to lead to deoxygenated blood being put to the entire body. So you have a lot used the mnemonic to help me remember the four pathologies. So that's going to stand for pulmonary stenosis, right ventricular hypertrophy, overriding aorta, and ventricular septal defect. So now, how is tetralogy of Fallot going to present? Firstly, you may see an action systolic murmur. This is because of the turbulence caused by the pulmonary stenosis, and this is often best heard over the left upper sternal border. You also see cyanosis, so a bluish tinge due to deoxygenated blood being circulated. You may see clubbing of the nails, which is commonly associated with hypoxemia, hand in hand. And that's going to be poor feeding and poor weight gain. So because feeding has such a demand, infants may tire very easily, which is going to lead to, now if they aren't feeding very well, they also aren't to gain too much weight. All right, I've been told to pause here again and do another poll for all of you. And the question for you is, most accurate measure of the severity of tetralogy of Fallot? Connor, if you could release the second poll for me, please. So you're going to have four options here. A, degree of pulmonary stenosis. B, degree of right ventricular, degree of cyanosis. And D, degree of clubbing.
So really got some responses coming in. People starting to go with degree of cyanosis at 60%. Give it another 30 seconds. Okay, I think it's settled on degree of cyanosis, followed by degree of right ventricular hypertrophy.
Okay, so I see where everyone is coming from. So I think we're going with B or C, but actually the answer is going to be degree of pulmonary stenosis. But why would? So if you think about it, the pulmonary stenosis is essentially going to be the driving factor for a lot of the problems that is caused by tetralogy of Fallot. As in, the right ventricular hypertrophy, for example, is due to the blood having to overcome the narrowing at the pulmonary vessel stenosis. Now, if there was lesser hypertrophy, the pressure within the right ventricle would be lower than the pressure at the, so then you wouldn't have your right to left shunt as well. And so that's not going to allow deoxygenated blood to the left heart and for it to be circulated through the body. And now if your deoxygenated blood is not going to be circulated through the body, you're not really going to see cyanosis or clubbing either. The answer for this would be the degree of pulmonary stenosis. And I hope that makes sense. Okay, let's now talk about spells. TED spells are essentially just episodes of cyanosis. So how exactly are these going to come about? So suppose you have a child who's doing an activity that requires a high amount of oxygen. Their oxygen demand is going to go up and compensate this by pumping out more blood. So it's going to do this. There's going to be a sudden drop in oxygen saturations because more deoxygenated blood is bypassing the lungs. and that is going to lead to cyanosis. Now, it's really smart, and so it's going to try to reverse this, assuming a knee chest position is young to be able to squat. And the reason it's helpful is because it's going to help, it's essentially going to resistance within the peripheral arteries. The peripheral arteries where there is going to be increased resistance. And now for the blood to be able to pass through increased resistance, you're going to have increased pressure. And the way to increase the pressure is that it's going to increase the pressure on the left side of the heart. And when that happens, it's going to reverse the right to left shunt and then get the child out of episode. Now, I appreciate that I threw a lot of information at you. I hope this diagram helped sort of simplify what I was spoke about. So there is going to be an increased oxygen amount, which is going to cause blood to be more blood to be pumped. That's going to drop oxygen saturations, leading to cyanosis. In response, the baby is going to squat, and that is eventually going to increase the pressure in left heart and reverse the shunt and get the baby out of cyanotic episode. Makes sense to you? So now, considering this, how are we going to manage tetralogy of flow? You're going to want to surgically manage it within the first year of life. You're mainly going to do this by doing two things. The first thing is defect, which you can do using a synthetic pouch. This is going to prevent mixing of blood between the two ventricles. The second thing you want to do is enlarge the pulmonary artery, also known as the right ventricular outflow tract. This will help reduce the stenosis and prevent further. Okay, so now that we're all experts with tetralogy of flow, and see what in his case suggests tetralogy of flow. Someone in the chat tell me about different clues in this question that might make you suspicious of TOF.
Some responses. We've got cyanosis and poor feeding.
Okay, I think for the sake of time,
and knee chest position
that is correct. And those are those are all correct, and those are all different signs that all suggest that Charlie has tetralogy of flow. We did speak about why you would see these signs earlier in the previous slides. So once again, I'm not going to go over it in much detail right now, but one of the signs that I talk about was the chest X-ray over here, and that is the boot-shaped heart. Now, the reason why you might see a boot-shaped heart in people with tetralogy of flow is because of the right ventricular hypertrophy. So instead of looking like a knot. Okay, so and is actively having a TET spell. So we've stabilized it for definitive treatment. Once again, you're very happy with yourself and that you're able to diagnose Charlie to treat yourself once again. But surprise, surprise, asked to review your third patient for today, who was Adam, a baby who was born at 38 weeks. He has no notable issues at birth, normal at 3.18 kilograms, and had no positive findings on his newborn exam. So he was discharged on day 2. Over the last day, his mom reported that Adam's feeding was quite poor and he started to get tachypneic. When you examine weak femoral pulses, you decide to measure his blood pressure, and that it differs between his upper limb and lower limb. The exact on the table on the right side of the screen. What do we also suspect here?
We've got coarctation of the aorta.
So yeah, the answer is going to be coarctation of the aorta. So what exactly is it? Coarctation of the aorta is just referring to a congenital narrowing of the aorta. So in the image that you see on the right screen, you're going to see this big red vessel, which is going to be your aorta. This part over here is going to be the arch of the aorta, and you have 3 branches of the arch, and that's going to supply everything, and that's going to supply your lower limb. That is the coarctation of the aorta. Now, before we structure, which is the ductus arteriosus right here, structure that is going to connect the pulmonary artery and the aorta. Keep in mind that this is only soon after birth. Now, what exactly is its purpose? So lungs aren't really functional for birth, so it's not going to be able to oxygenate any receives, which is perfectly fine because the baby is receiving oxygenated blood from the mother. But if the fetus is receiving oxygenated blood, there's no reason for that to go through the lungs. And in fact, that's actually going to be counterproductive because the fetal lungs just aren't developed enough blood coming in. That's where your ductus arteriosus is going to come into play. It's going to help shunt blood away from the lungs and will directly send it into the aorta for it throughout the body. Okay, so now that we know that, let's now look at, before we talk about the blood flow, let us first figure out what we're looking at. So this is vena cava, and that's going to drain into your right atrium. You're also going to have your inferior vena cava draining into your right atrium, by the way, but just for simplicity's sake, it's not included in this diagram. But just know that it is there. And that's going to make this your pulmonary artery. This little bridge that you see is going to be your arteriosus that we just discussed. And so that is going to make this your aorta. Right underneath that, so these 3 little branches are the branches of the aortic arch. So that's supplying your upper limb and your head and neck over here that's labeled already. So if this is your, you can sort of figure that this is going to be your left ventricle, your left aorta, and also your pulmonary vein. Okay. Now we know what we're looking at. So let's now talk about the blood flow. You can receive blood from SVC and IVC, and that's going to go through the right heart and then go through the pulmonary artery. Now, because the ductus arteriosus has a choice to make, it can either go through the ductus arteriosus to flow within the pulmonary artery. So let's apply the principle that we just learned where blood is going to flow. You may think that the blood will continue to flow through the pulmonary artery since on the right side. Partially correct to think so, and I understand why you would do that. The coarctation is going to complicate things a bit more for us. On the left side, as usual, the blood is at a very high pressure. And because of the coarctation or the narrowing, it's going to have to flow at a higher pressure for it to or very high pressure on the left side. After it passes the narrowing, it's going to start to lose a lot of energy. So it's going to have very low blood pressure right after the coarctation. And it is so low that it is lower than the right side of the pulmonary artery, but rather will flow through the duct and will then continue to flow through the aorta. Okay, so now that the unknown is going to affect this, let's now see how that's going to impact the blood. So firstly, you're going to see a difference in blood pressure between the upper limbs. This is going to correlate to the blood pressure after the coarctation. So anything that is supplied by the structures before the coarctation, that is the upper limbs, you will have a higher blood pressure because the blood is trying to overcome the narrowing. Anything that is supplied by the structures after the coarctation, like the lower limbs, will have a lower blood pressure since the blood is losing energy after overcoming the coarctation. Sort of piggyback concept, you're going to have diminished is going to be quite low down at the lower limbs, so it's going to be much harder for you to treat. You may also hear ejection systolic murmur because of the turbulent blood flow and in coarctation of the aortic sac at the left infrascapular region. You may also feel a left ventricular hypertrophy, which, again, if you think of it, it's going to make sense because the left ventricle is going to have to pump really, really hard for create a high blood pressure blood to pass through the coarctation. So there is going to be left ventricular hypertrophy and the left ventricular heave. Finally, a child may also have underdeveloped legs due to chronic reduced. Okay, now a next poll question, and that is, which of the following best way to diagnose an aortic coarctation? Connor, if you could release the next poll question for me, that would be well. Thank you. So we have 4 options here. Option A is going to be, option B is going to be an echocardiogram. Option C is a chest X-ray, and option D is a cardialization.
So far everyone's voting for echocardiogram.
Okay, amazing. So the answer is fact an echocardiogram. So I'm very correct. This is going to be the best way, and it's actually going to help you visualize the structure of the heart. Unlike an ECG and a chest X-ray, you're not going to be able to really visualize the structure of the heart, and a cardiac catheterization is just quite invasive. So you probably wouldn't go with that as your first. What you see on the right side of your screen is an echocardiogram of someone with coarctation of the aorta, and this white arrow over here is highlighting the narrowing of the coarctation. And if you sort of follow through above, you're onto treatment. So the first thing you want to do is maintain the patency of the ductus artery, because this is what is going to help maintain a relative amount of blood flow going down to the lower extremities. You're going to do this by administering prostaglandin to stabilize the baby. You're also going to have to surgically repair the coarctation. So that's when you consider surgical repair. So you're again going to vary. So if you have a short segment narrowing, you can do something called an end-to-end anastomosis. So for this, I'm going to cut out the bit that is narrowed, and you just stitch the 2 healthy ends together. Simple enough. For a medium length segment narrowing, area that is involved for you to be able to do an end-to-end analysis, you're going to essentially reconstruct the arch with a patch and then fix the narrowing. You can also do 2 types of percutaneous repair. So first, you could have, you're going to thread a small balloon into the narrowed part of the aorta and then improve, which is essentially just going to widen the aorta and then improve flow. Sometimes the balloon may not always be successful, and that's where you have a stent come into play. And a stent is essentially just a tiny into the artery, so it's going to help hold the artery open, prevent the narrowing from reoccurring. Okay. So that's the management case. Let us consider what presentation suggests that had coarctation of the aorta? I'm going to give you all a minute to go through it, and if you guys could put your answers in the chat, that would be helpful. Okay, so just for the sake of time, I'm going to move on. Hopefully you guys are thinking of answers at least, if not putting them in the chat. So I have highlighted the over here on this slide. And again, we have gone over this previously. So if you have any specific questions in this regard, please let me know. Okay, lovely. So now we've solved Adam's case and you're very happy that we were able to diagnose him. This is a bit of a difficult one as well. So just as soon as you leave your room, you get another bleep, and now you're asked to review your next patient, male baby, and was delivered via a vaginal delivery, but was still able to breathe and had a patent airway since she was able to cry. Upon auscultation, you were able to hear bowel sounds on the left side of the chest. Her breathing was worse, and then she started to develop respiratory distress. The baby also seemed to be using a lot of her accessory muscles while breathing. Let's take an X-ray to see what's going on. And what you see on the right side of your screen is nasal. So what condition are we thinking about here?
Put your thoughts in the chat, guys. We've got CDH from Luca.
So CDH would be correct. So for anyone who doesn't know what that stands for, that's going to say congenital diaphragm hernia. So CDH is a development that is going to lead to the protrusion of the abdominal viscera into the thoracic. When it comes to diagnosis, these are usually diagnosed with a 20-week scan. This doesn't always happen. So there are some signs that you need to look for postnatally as well. So one of the signs that you might see is reduced breath sounds on the affected. For example, that the abdominal viscera has herniated into the left chest. You may hear reduced breath sounds on the left side, hence the affected side. You may also see something called scaphoid abdomen because the abdominal organs that are supposed to be here have migrated into the chest cavity. The abdomen is essentially going to be underfilled. This also is going to result in a sunken or a concave appearance of the abdomen, hence the term scaphoid abdomen. Now, finally, you may see bowel above the diaphragm X-ray, like what you see here on your screen. So, because the intestines are passed through the diaphragm and have gone into the thoracic cavity. So these tubes, what we see over here, shouldn't essentially be in the thoracic cavity because they are the intestines, and because of the hernia that is present at it has gone up into the thoracic cavity. Now, yes, that you might see. The most common is the bulkhead hernia. This refers to when the abdominal viscera have passed through the posterior to be the anterior aspect, and that is the posterior aspect. The defect. So as you can tell over here, it's present posteriorly and on the lateral aspect of the diaphragm, non-bulk, and these are usually a lot less common. These are the ones that occur more anteriorly through the foramen of which these occur usually near the stem. They are often on may also be asymptomatic, may be found incidentally. Okay, let's move on to my final poll question for all of you of congenital diaphragmatic hernia. Connor, if you could release the final poll. Thank you. So once again, we have four options. You have A, pulmonary hypoplasia, B, meconium ileus, C, necrotizing enterocolitis, and
So we have everyone voting for pulmonary hypoplasia.
amazing. So we're often worried about pulmonary hypoplasia when we see kids with congenital diaphragmatic. The reason why you might see pulmonary hypoplasia is because developing lungs in utero, and that's going to restrict normal lung cells in hypoplastic or underdeveloped lungs. These over here are some more presentations that you might see in CDH. If you were to see a large hernia, I'm not going to go into too much detail about these because we did talk about some of the important presentations earlier on. But I essentially just needed to know that a lot of these presentations are going to be caused by the abdominal viscera pressing on the lungs, and so the lungs aren't going to be able to function. So you'll see things like respiratory and cyanosis because of that. One thing I want to highlight is the displaced heart sounds. So when the abdominal viscera is within the thoracic cavity, it's going to push the heart and it's going to essentially move it away from the original location, and hence you will hear displaced heart sounds. All right, if CDH is diagnosed prenatally, you can do something called FETO, which stands for trachea. It's going to be a really fascinating procedure because you're treating an unborn child through the mother's womb, and this whole concept just seems really cool. But I'm going to stop fangirling over it, and I'm going to tell you more about the procedure. So, you know what a fetoscope is? It's essentially just a very thin, flexible camera. Now, this is going to allow us to enter the amniotic cavity and visualize this. And for this procedure, specifically visualizing the mouth and the air, you're going to guide the fetoscope through the mouth and down the trachea, and you're going to carefully place a tiny little balloon into the trachea. Once you're in position, you can confirm this using an ultrasound. While this may sound counterintuitive, the whole purpose of this is to trachea. So by doing so, the fetal lung fluid out, and instead of escaping into the amniotic fluid, it is going to stay within the lungs and will promote lung expansion. This expansion is going to stimulate lung growth. Now, as the lungs are going to herniated abdominal viscera out of the chest and back to the abdomen, and it's going to relieve pressure off of the heart, and it's also going to allow for development. As I said, it's a really cool procedure. I would highly recommend watching an animation on how it works so that you can sort of better visualize what I'm talking about. Okay, so this is what you do in utero. But what if you were to figure out that the child has CDH after they're born? Well, you have three options based on the. So if you have a small hernia, you can do this is just when the edges of the diaphragm are essentially just stitched together without adding any tension, meaning that the tissues can meet them being having to stretch or hold repair. And this is if the hernia is slightly larger. So when you do this, that is either synthetic or made from biological material, and you're going to cover the reinforce the diaphragm. The final option here, you're going to use a piece of the patient's muscle, and you're going to essentially just use that as a patch to go and then reinforce the diaphragm. Okay, so now that the drill, let's review May's case again and think about what you to put your answers in the chat just for the sake of time. This and think about your answers. if you are keen on putting it in the chat, you can. But I'm just not going to wait until you guys respond. Okay, so I'm going to move on and add the different points that tell us that we might have CDH. Again, we have gone over this, so we'll understand why you may see this. And if you have any questions on this regard, please put them in the chat and I will answer them at the end. Okay, so you've had a busy-ish shift, but on the right, it's almost over. So you're almost there now. But as expected, your bleep goes off again and you're not. Sally is a newborn baby who was delivered via a C-section, and this was around 39 weeks. The reason the C-section was scheduled was because it detected an abdominal wall defect during the 20-week scan. Fast forward to today, where Sally is born, you see that her bowel and part of the abdominal viscera is covered by a translucent sac. So consider this. What condition do we suspect? This time I am going to ask you to put your answers in the chat, so please them in the chat, and if you could read them out for me, that would be helpful.
So straight away we've got Alacil from
Amazing. And in Valacil, the abdominal contents are going to herniate outside of the baby's abdomen and is going to be covered by a membranous sac. This part of information, the sac, is going to be really important. And we'll talk about why later on. Now, there are two main risk factors that you need to remember. So think about 40 years or so is going to increase risk of developing Valacil. You have maternal switch, which can increase the risk of the child developing an infection. Now, obviously, when it comes to diagnosis, you should ideally be able to see that the abdominal viscera has been of the abdominal wall. But sometimes you can also diagnose this prenatally, as we were able to in Sally's case. And you could do that using an antenatal ultrasound, which you can have here. You can see that this area over here is the herniated organs. And you can also see that there is a nice colors from the fetal tissue. This is not going to be diagnostic. So there could be a whole bunch of other reasons why you might see high AFP, but it might suggest that there might be something going on, such as an Valacil. Okay. So now the baby is born, and now you have to act really quickly to help it and then fix the problem. So to stabilize the baby, you are going to initiate fluid resuscitation, lose a lot of fluids. You're also going to have to help them with regulating the host organs are going to make prone to hypothermia. So it's really important that you're able to keep the baby warm as well. You're also going to draining the swallowed air, which might have happened when the baby was crying. By doing this, pressure on the diaphragm, and that might also help the baby breathe a bit more comfortably. So after you baby, you can now surgically repair the defect through something called primary repair. So this is you very gently pushing the bowel to the abdomen, and this has been reduced. You can then close the abdominal wall and fix the abdominal defect. Now, while you were reviewing, you were reminded of another piece you saw the day before, quite a very similar presentation, and his name was Oliver. So just for some context, Oliver is a full-term baby delivered by a spontaneous vaginal delivery. When he was born, this is a cluster of loops of bowel protruding out of his abdomen. She mentioned that the bowel looked really angry and inflamed, and noted that there was no protector. This is the last ask guys to answer in the chat. So if anyone could tell me what condition do you think was diagnosed with before?
And again, straight away, we got a gastroschisis.
All right, that is also correct. Oliver is diagnosed with schisis. So gastroschisis is going to be slightly, in this case, the abdominal viscera is going to herniate through an opening within the abdominal wall, but it is not going to have a protective membrane. And that is the major difference between gastroschisis and an omphalocele, so the protective membrane. Okay, so again, there are two main risk factors for this. One is maternal smoking, and this time you need to think about the other end of the spectrum. So typically younger mothers, so those who are age 20 and below, are at a higher risk of developing gastroschisis. The way I tend to remember that older mothers are at risk of developing an omphalocele. So you see O and O, so that's telling me older mothers, omphalocele. So younger mothers is going to be gastroschisis. All right. Now, once again, for diagnosis, hopefully you will be able to look at the baby when they're born, but also you can prenatally as well. So you can do an antenatal ultrasound again. And over here, you can see the herniated organs. It's slightly different from an omphalocele is that the herniated part does not have a very smooth border around it. So hopefully you'll be able to tell that there is an irregular border over here. One of the differentiating, obviously you would also have to do some further testing for you to fix schisis or not. The second way you could sort of suspect gastroschisis and not is high alpha beta proteins. The same thing with an omphalocele. And again, this is because the fetal tissue is exposed. So that's going to start leaking beta protein into the sac. Okay, as for management, your priority first is going to be to stabilize the baby. And the first step to take is the same thing as what you would do in an omphalocele. So you're going to risk of developing hypothermia and also hypovolemia because of the exposure of the bowels. Now, because in gastroschisis, you aren't going to have to cover the bowel with a sterile material. And the main purpose of this is to prevent infection and to maintain moisture of the organs. So once you do that and the baby is stabilized, you can now go for surgical repair. If the defect is smaller inside, you can do a primary repair. You're going to try and reduce the protruding. You're going to do this very gently, and then repair the abdominal wall defect. Saddle bag. And this is essentially a little bag where you can put a bowel within it, and the bag is the organs into the abdomen. Eventually, you will be able to reduce the abdomen, and once you're able to do that, you then go to the abdominal wall and restore normal anatomy. Okay, hopefully you'll all be able to appreciate that omphalocele can have a lot of overlapping conditions for rather features. And what I want you to take away is that an omphalocele is going to have a protective membrane surrounding the hernia, whereas a gastroschisis is not going to have the protective membrane. There are also a couple more differences, and I'm not going to go over them in a lot of detail, but I have made this table for you, and you can. Okay, I promise we're almost end. I just want to quickly have you guys over and think about why we diagnose them with an omphalocele and gas respectively. Again, I'm not going to ask you to put your answers in the chat, but please do take a minute to it, and I will show you the answers in just a second. Okay, so these are your answers over here. The answers make sense, and again, any questions, put them in the chat. With this, I am very happy to tell you that your shift has finally come to an end, so you finally go home and get some rest from your day. Before I hand over to Connor to close the session, I just wanted to direct you to extra resources as well. So I want you towards the barking cough and systolic murmur specifically. So these are some clinical features that you should be able to pick up on, and I wasn't able to also shows you how an ejection systolic murmur sounds like. It's very important that you know what these look like and sound like, not in keys, and also you need to be able to look at it. And I have also added a link. So we spoke about this when we were talking about esophageal atresia and tricuspidal fistulas. I didn't go into too much depth about it, but you have a good read of this website. They have a very good resource on what tracheomalacia is and the problems associated with that. And finally, my favorite, it's a really, really interesting procedure, as I told you, an animation, which you can watch and sort of visualize what I was talking during the session. Okay, I'm now going to stop talking and let Connor take over and question for all of you. Thank you all for listening.
Thank you so much, Sheeta, and thank you all you guys for attending it and engaging with the session throughout. Nice to see the response on walls and some mess chat, so thank you for that. Yeah, some great further reading there from. I also implore have a look at the emergency management of gastroschisis and non-seals in low resource setting. There's some fantastic, very ingenious solutions when a silo bag is like sterile urine bag or empty saline bags and things like that. It's about that. Our feedback form is now in the chat, it should be in a sec. There you go. So please fill that out. Receive your certificate, complete it. You'll get your discounts codes for Teach Me Surgery and pass the MRCS. Also be sure to complete the Google form for a chance to win Geeky Medics surgical flashcards and their stations. Should also be in the our final session of the 2025 medical student SUPTA series will be tomorrow, and it will be acquired pediatric conditions. That will be started at the same time as today, 6:30 p.m. British summer time. That will be the last session of the series. It'll be a great way to close and get your final code if you want a chance of a prize. Make sure to follow us on all these, and as we'll be posting some more questions to help recap the session, links to our next and any other activity that we'll be undertaking. Don't forget to visit our website. This is our free learning portal, that's SUPTA.uk, and you'll get access to all of our previous recordings, free multiple choice questions, and session summaries, written session summaries, which will be great with your upcoming exams. So everyone, I hope you're valuable. Thank you again for joining us, and we look forward to seeing you tomorrow of this year's teaching series. Thank you so much, Peter.
Thank you, everyone.
I'll give you all a few minutes to complete the feedback, and then I'll close the session.